In this talk, I'll be taking you through a journey about progesterone. We all understand progesterone, but when we look back, we really don't understand what is progesterone. In this journey, I'll be taking you why we don't understand progesterone, and more understanding of the progesterone is coming in. One might think progesterone is as simple as luteal phase, where after ovulation the progesterone gets produced, and nothing more, nothing less, and it's a secondary molecule to the estrogen. But in the last 10 years, more and more work is coming in about the progesterone receptors, which are three different types, which act differently based on the type of the molecule, be it natural progesterone or the synthetic progesterone. Progesterone is a complex molecule. A simple change in the side chain will alter its action from a natural progesterone to an action on the corticomedullary corticoids and CRP, and also acts at the neurological levels. This is being unraveled. In this talk, I'll be taking you through a journey about what are the controversies that are happening in luteal phase deficiency, what's the role of progesterone in pregnancy and in infertility. But before that, when we look at progesterone in gynecology, there's a huge world opening up. You see its role, as all of us used, in the use of HRP, in the regulation of bleeding of menstrual cycle. It's also a positive modulator of the GABA molecule. Progesterone in the natural form is an anxiolytic, antidepressant, and a lot of studies are happening about its role in premenstrual syndrome. And it's also being used in the stroke management and in the premature babies. And the other thing is, it also has a natural progesterone also has a certain amount of diuretic activity, but not the least is it acts on the osteoblast and osteoclast, and its role in future might be along with estrogen in the management of postmenopausal women, because these are the changes that are coming in. And what we realize is progesterone early a menstrual period and a pregnancy and an abortion. But there's more than that. In the coming decade, we'll be seeing on this. When we come to pregnancy, it has a role in the implantation, it has a role in uterine contractibility, and it has a role in the cervical ripening by its action on the CRF, where it halts it to prevent expulsion of the embryo, fetus, and the baby. And once that mechanism fails, the prostaglandin pathway is activated and it leads to a lot of catastrophes. When we actually come to luteal phase support, we are really confused about what the concept of luteal support is. Is it same as luteal deficiency, as Georgina Seeger-Jones has pointed out, or this is something different? Or is it in the field of ART the luteal support comes in, which I will be explaining. In a normal cycle, you have the progesterone, which gradually rises and then falls, whereas in an IVF cycle, because of the multiple corpus luteins, there is an enormous rise of estrogen and progesterone, which in turn have a negative feedback on the LH and produce LH deficiency, which in turn produces an insufficient corpus lutein production. So the role in assisted reproduction luteal support is radically different from the common areas where we are being treated. In the luteal phase deficiency, initially it was first identified in 1949. Later it was thought as a deficiency of progesterone production, which was corrected by exogenous progesterone by Jones, and the prevalence of luteal phase defect in natural cycles was thought as high as 8 to 12%, and it was a common question for many times. But here I'm going to take you to a journey of changing concepts in the luteal phase. if we do not answer in a post-graduation what is luteal phase deficiency, where we are supposed to tell 10 days, mid-luteal phase progesterone elevation does not happen, and it's out of phase for 2 days in the endometrial biopsy. How often do we see this situation, and how often do we diagnose this situation? And this is reflected in a committee's opinion. ASRM produces committee's opinion, and this is the only document which has been revised in the last 10 years 3 times. In 2012, the title of the committee's opinion is The Clinical Relevance of Luteal Phase Deficiency, Committee's Opinion. Later, in 2015, we have current clinical irrelevance of luteal phase deficiency. So I am repeating, in 2012, clinical relevance of luteal phase deficiency, and in 2015, clinical irrelevance of luteal phase deficiency. So the thought processes are changing, and in 2021, it was replaced by diagnosis and treatment of luteal phase deficiency. In 1 decade, this is the only topic where the committee has revised its position. That speaks volumes about our understanding, the deficiency of understanding about the luteal phase defect and how it is being underdiagnosed or overdiagnosed. So what happens is, now people are realizing there are essentially 2 causes: primary luteal phase deficiency and secondary luteal phase deficiency. The secondary cause of luteal phase deficiency is by the GnRH pulsatility change in amplitude and frequency, which then affects the LH, which is seen in hypothalamic amenorrhea, eating disorders, excessive exercise, weight loss, stress, obesity, polycystic syndrome, endometriosis, aging, undiagnosed 21-hydroxylase deficiency, thyroid dysfunction, prolactinemia, ovarian stimulation, and assisted reproduction. These have replaced what we have been taught in our undergraduations and postgraduations of luteal phase deficiency of 10 days, less than 10 days, with luteal phase progesterone being abnormal and the endometrium being out of phase. This is the change in thinking process. In a recent study, when they overlapped the degree of progesterone changes that happen of more than 10 nanograms, they found only 62% of the people, women who had regular menstrual cycles, had more than 10 nanograms in the mid-luteal phase. The rest of them formed the various spectrum. The error in the diagnosis, in a given day, the progesterone can vary between from 8 to 40, depending on the pulsatility of the LH, and between how often you are doing it, whether you are doing a pooled sample or a single sample. So that makes a whole difference. So the diagnostic criteria as per ASRM is, it is a clinical diagnosis, but none of the diagnostic tests that are used, be it clinical, biochemical, histological, they are not able to differentiate between a fertile and an infertile people. So the proposed treatment for luteal phase deficiency is correction of the underlying condition which primarily causes the secondary luteal phase deficiency, and the role of progesterone is more empirical rather than scientific. And one major statement at the conclusion of the committee's report in 2021 is idiopathic luteal phase deficiency has not been proven to be a cause for infertility. So we have moved from a place where luteal phase deficiency was a common topic and a common class. From there we have moved to saying whether it really exists or not. That's the current scenario. And there is no evidence that progesterone is beneficial for luteal phase deficiency, because that is the end result rather than the primary problem. The data on the use of progesterone supplementation for recurrent pregnancy loss are conflicting and might not be reflective of the patients with luteal phase deficiency. In other words, the concept of luteal phase deficiency is evolving, and in the next 5 years we'll have much more clarity as more receptor information comes in and the mechanisms are understood. When we come to ovulation induction, a lot of us give routinely progesterone in induction of ovulation, but the evidence is contradictory. If we are using oral induction of ovulation, be it clomiphene citrate or letrozole for anovulation, the evidence shows there is scant role for progesterone in induction of ovulation with medication. There is only one small study which investigated the clinical efficiency of luteal phase defect in the role of clomiphene citrate, and that too that was published in 1990, and no study has been published after that. This reflects the changing knowledge and the changing priorities of the drug. And in 2022, there is a paper in RB Online, luteal phase support with progesterone does not improve pregnancy rates in patients undergoing ovarian stimulation with letrozole. So, in conclusion, what the literature says is the role of progesterone support in induction of ovulation, especially when you are getting monofollicular developments, the role of luteal support may not exist, and it's only in a small percentage that might exist, but that percentage is unknown as on date. When we come to miscarriage rates, there are estimated 23 million miscarriages every year, and the risk is around 15% of all recognized pregnancies, and 44 pregnancies per minute are lost worldwide. But when we look at the data about the recurrence of pregnancy loss, with the changing number of children and the demographic shift of the population growth coming to 2.1, the data is becoming more not sufficient for recurrent pregnancy losses. Here you see, when you're in the first column, you see the first no pregnancy loss, you have 3,62,000 women in all the studies put together. In one previous miscarriage, the numbers are falling to 70,000. 2 or 3 pregnancy losses, the numbers are falling to 16,000. 4 pregnancy losses, they came down to 2,000. And in 5 pregnancy losses, it came to 732. Are these statistics valid? These are combined studies of the published data. So when we speak about multiple pregnancies, we should look at into the current century. How many other families are having multiple children, and what's the age of the marriage before they undergo any intervention procedures. Now, time to conception has become a priority compared to yesteryears, because the age of marriage in the last 1 decade has shifted by a decade. So the priority of time to conception and more interventions are coming in. So there is an overlap of treatments between assisted reproduction and management of pregnancy losses. This is a schematic diagram of the human progesterone receptor, which are 3 types, A, B, and C. The C is related to more into abnormalities of preterm labor. A and B have a role in the endometrium implantation and early pregnancy and the menstrual disturbances. When you look at the regulation of endometrial activity, the bold lines show that that's where progesterone acts. In the epithelium, it acts at the stops the proliferation of the epithelial proliferation, also acts on the calcitonin. When you come to stroma, you have a lot of transcription factors like FOXC01, then you have CEBT, then you have amphiregulin. All these are altered by progesterone, and this is going to change the way we manage dysfunctional uterine bleeding, the way we manage pregnancy losses, because this is an evolving information. And in fact, there is a mistake in the citation. It's a 2019 citation rather than 2013 as it is written. When we come to micronized vaginal progesterone, a woman with a history of miscarriage who presents with bleeding in the early pregnancy, with a previous history of miscarriage and a bleeding in this pregnancy, may benefit from use of vaginal progesterone, that too at 400 milligrams twice daily. And this has been identified by 2 different trials. One is the PROMISE trial, in which they have used progesterone in comparison with the placebo and found a difference of 4% benefit in the second and the third pregnancy, but not in the first pregnancy. And the PROMISE trial was a big trial, and the outcome was those who were treated with progesterone till 12 weeks and then looked at what was the outcome. Then you have another trial which is called the PRISM trial, where by the number of previous miscarriages, progesterone was given. The findings of the study is progesterone is likely to be cost effective for all women at risk with a previous abortion and also bleeding in the current pregnancy with a previous loss. And this is where they found that it is effective, but there is a question about cost effectiveness. This study is unique because it is a health economic study apart from a scientific study. Here you see the PRISM trial, the cost effectiveness of progesterone in preventing miscarriage in women with early pregnancy bleeding, an economic evaluation. You have 4 quarters. The top one is more costly, the left side is less costly, less effective. Then the right side top corner is the more costly, more effective, and less costly, more effective. And progesterone, vaginal progesterone is falling into a more expensive option with certain amount of benefit. This trial was done in UK because all the medications are funded by the NIH, so that is the reason to have a cost benefit analysis. Maybe in future with the predominance of Argosy and the Bharat health programs, we might have some of these programs saying how cost effective is the intervention. We are also seeing the audits of the C-sections and the hysterectomies that are there, and with time, it's a question of time, this economic audit might come into our country. In preterm birth, there is a profound role because vaginal progesterone and to a certain extent 17-hydroxyprogesterone is a risk factor reducer in people with high risk factors, and it acts at the effector P cell role where it stops the performing growth and prevents the preterm labor. And this is where the vaginal progesterone is making a difference. And they are finding the results with 17-hydroxyprogesterone and vaginal progesterone are similar, but there is one difference. In high-risk women, the starting of vaginal progesterone is much earlier than hydroxyprogesterone. That's a difference. But when you look at cost effectiveness, hydroxyprogesterone, if it started early, maybe it makes a cost difference. But the whole action is coming at the T cell effector T cell. So immunomodulation progesterone role is playing a major role. And this is an article with the ADOG, prevention of preterm birth with vaginal progesterone or 17-hydroxyprogesterone. They found both of them are equal. The only difference they found in the study was when they corrected the people of the starting of the drug, they didn't find any result difference. Whereas if they compared the one which had an early start of vaginal progesterone, then there is a difference. That means if you compare the starting of the drug for high-risk patients with the previous pregnancy, preterm deliveries, if you start early progesterone, be it 17-hydroxyprogesterone or vaginal progesterone, be it micronized or fluorouracil, the results are efficient. And there is another publication which is published in 2022, where what they found was in patients with singleton who had a previous spontaneous preterm birth, vaginal progesterone therapy led to a later gestation age of delivery compared with 17-hydroxyprogesterone. But this study was underpowered. But here are 2 concepts which are coming in: the role of progesterone in preterm labor, be it vaginal progesterone or 17-hydroxyprogesterone. But this data does not apply to the parental progesterone of other molecules or dihydrogesterone. This applies only to the natural progesterone or 17-hydroxyprogesterone. That's a difference. When you come to luteal phase defect in a stimulation cycle, in 2005 it was realized when downregulation started, they realized that we are creating an artificial luteal phase deficiency by producing too many follicles and a significant drop of estrogen progesterone. So there were studies from that time, and at that time the availability of progesterones were less. Initially they were prepared by the pharmaceutical pharmacists, then gestone came in, then micronized progesterone came in, and with time the gels have come in, and now water-soluble subcutaneous progesterones have come in. So there is a choice of drugs. So in an IVF cycle or in a controlled ovarian hyperstimulation, if you are giving a HCG, the luteal phase needs less support but not absent support. Whereas in an agonistic cycle, the luteal phase is very short, which I will be showing you in a minute. In a natural cycle, in a mid-cycle, the LH levels are 6 milliunit international units per ml liter, whereas in a GnRH triggered antagonistic cycle, the mid-cycle LH is 1.5. That means when the LH is low, the progesterone is low, and that is where the need for supplementation is there. If we identify this, then we can minimize the number of freeze-all cycles and go for fresh cycles. That's its evolving area. So if you look at this figure, in a GnRH cycle, once the medication is given and the egg pickup is given, the LH cells that comes in is over by 32 hours, and after that you don't have any activity of LH, neither progesterone, and you have a luteal phase deficiency which is produced by iatrogenic features. This is where we are supposed to treat what we have created it. Whereas in a HCG injection, also, depending on the number of follicles, the body mass index of the patient, and the health conditions of the patient, the dose of the HCG should be titrated. Because some of the HCG preparations are subcutaneous preparations, and if we inject it into the fat, the absorption profiles will not be proper. And most of the HCG dosage of 6,500 units or 5,000 units urinary products are designed for a woman who has BMI of less than 30. So we have a policy, if the woman is more than 30, we give the subcutaneous injection only on the arm because the fat is less, and also increase the dose of HCG so that there is an adequate amount of surrogate LH to act. So the role of HCG preparation and the dosing is also important based on the BMI. The effect of progesterone on the endometrium is secretory. It regulates the window of implantation, vascularization, it's an immunomodulator and a contractor. Why do we have different types of protocols for progesterone? Here is an excellent review which says how the concepts in US and in Europe are different. Luteal phase supplementation of a GnRH agonist in a fresh embryo transfer, the American versus European approaches. And what do we have Indian approach, or are we combining both? That is what Dr. Prabhu was commenting indirectly. So when you look at here, in the European approach, a HCG is given and it promotes the endogenous steroid production. Whereas when you come to the American approach, they rely on more exogenous support. But in India, we end up doing both because we read this literature and this literature, not realizing that the health economics and the philosophies are different. When you look at Europe, most of the IVF programs are state-sponsored programs, whereas in US you see co-pay or own money. So the approaches of the European concept and the American concept are different. But unfortunately in India we have mixed them together and using it both. The recommendations of ovarian stimulation in IVF suggests progesterone is recommended for luteal phase of IVF for all cycles. So in the fresh cycle, it is started on the day of the egg pickup. Some people give a day later. But the dosage is, if it is micronized progesterone, there is a certain dosage. If it is a gestone, certain dosage, which I will comment in a minute. Then, in a frozen transfer cycle, if we are doing a natural cycle where we just allow natural ovulation to happen, we don't use progesterone at all. We allow the nature to take its course. That is gaining importance. The reason is, in frozen transfer cycles, where estrogen and progesterone are given, the incidence of preeclampsia has significantly increased. So the trade-off or the complication which we are producing in a freeze-all frozen transfer cycle with estrogen and progesterone is an increased incidence of eclampsia, preeclampsia. And why it is happening, the data does not show at this moment. In time it will tell us. So yeah, because of that, a natural cycle, a modified natural cycle is coming in. The complete artificial cycle is where you give estrogen and progesterone. And in certain people, they stimulate so that the corpus luteum functions. There are cocktails of things. The key message is different methods of endometrial preparation and luteal support are equally effective, but does not mean use all of them. Decision should be based on the clinical experience and the patient's preference. The duration of progesterone exposure and dosage might impact pregnancy outcomes, be it too low or be it too high. When it comes to route of administration, we have the intramuscular 50 milligrams once daily, 25 milligrams subcutaneously, vaginally 90 milligrams gel, or 200 milligrams 3 times micronized progesterone. And then you have the one more suppository which is not oil based. Most of the micronized progesterones that we use vaginally are made from vegetable oil, and there might be some people who are allergic. That's where the starch-based progesterone is used to prevent that complication. When it comes to the route of administration, there are cocktails of preparations. There is no uniform policy, but ultimately you have to give one adequate dosage of progesterone so that to support the luteal support. How do you do that? Now, people are measuring the progesterone value. In a fresh cycle, the value should be 40 nanograms. In a frozen transfer cycle, if you are using a vaginal preparation, it should be about 9 nanograms. So there is parameters coming in. Below that, you have to supplement the second dosage only, not for every patient. In a survey which was done by the IVF worldwide, the predominant progesterone that is used is vaginal preparation, 11% is intramuscular, and only 1% give both, 3% give both. So actually a combination of drugs is given in less than 8% of the people. So reflect on your practice, seeing whether you are following that 8% of giving multiple drugs, or for every patient you are giving multiple drugs. That's an important carry home message. When it comes to dehydrogesterone, there is a controversy that is arising because unlike micronized progesterone, this is a synthetic progesterone, and there are conflicting reports about its potential cardiovascular abnormality on the fetus. That's an area that is coming in now. But the committee has not recommended not to use it. If you are using a vaginal progesterone or intramuscular progesterone, anything singly is equally efficient. So the data of vaginal versus intramuscular, no difference in implantation, miscarriage and live births. It does not mean we have to give both. And when you look at the progesterone value, the parameters are different. When you look at the red, that is the intramuscular progesterone, your serum values will be high, but your endometrial values will be moderate. But the mechanism of action are not equal, their structures are not equal. When it comes to micronized progesterone, your blood values are at 10 nanograms, but your endometrial levels are quite high. So it all depends on the route of administration. All the macroprogesterones are not efficient because of the degradation products. Whereas for the dehydrogesterone, people are giving it and they're getting equal results. But the word of caution is follow up the patients and be on lookout for the literature about the adverse effects so that you are not caught unaware of that progress. So the mode of application of vaginal progesterone, be it gel or progesterone, are similar. Only it's a question of convenience. But when you look at the therapeutic levels, here you're seeing 100 milligrams of pessaries, this is the blue color. Then you're seeing 400 milligrams of pessaries, that's the green color. And you're seeing 90 milligrams of gel OD, that's the light blue color. So even with single doses, you're getting adequate levels of progesterone. There is no need to give multiple drugs. Intramuscular progesterone has one advantage, but the pain to the patient is very, very severe. And in a very small situation, an allergic reaction. Subcutaneous progesterone is gaining acceptance, but more data is needed. But the recommendation says about dihydroprogesterone, when compared to progesterone, dihydrogesterone has similar ongoing pregnancy rates. Current evidence shows similar safety and tolerability. However, the committee considers these safety data is insufficient to make a firm statement that is there is either a presence or lack of a definite abnormality. So a word of caution is being put out. Then you have one more thing called dual trigger. That means you give the HCG or the GnRH by the number of follicles you have and titrate the dose of HCG. In this, what happens is, if you are having 14 follicles, then you give a GnRH with 1500 units of HCG. If you have 15 to 25 follicles, you reduce your HCG. And if you have 26 to 30 follicles, you further reduce your thing, but can do fresh transfer cycles and reduce the incidence of hyperstimulation. Because titrating the HCG will reduce the amount of increase of VGF. But when there are more than 30 follicles, resolve. This is widely followed in the European countries. Like I said, measuring progesterone in frozen cycle, see that you're measuring it within 4 to 6 hours after the last usage, not 8 to 10 hours, because you might get a less value. So in a frozen cycle, with vaginal progesterone, the cutoff values are 9 to 10 nanograms with 25% variation. Whereas in a fresh luteal cycle, where you have many follicles, it is 40 nanograms. So dosage monitoring is coming so that it makes our job easy and patient friendly and avoid too many drugs, because you will have ending up with multiple drug to drug interactions and a compliance issue, because if somebody is taking 20 tablets, how are you sure that they are taking them? Finally, I thank the chairpersons and the Zydus team for giving me the opportunity. Thank you.